something special about their country. I'm going to introduce myself in Spanish. Soy María, soy de Guatemala. So estoy terminando medicina y estoy súper feliz de estar aquí con ustedes. And yeah, that's my introduction in Spanish. I recently retweeted something that said my Spanish me is so much more outgoing than my English me, and that is true. That is so true. I don't know, Kiara, do you want to introduce yourself as you have a Spanish you as well?
Hi, I also speak Spanish, and I'm Kiara from Peru, and I'm so happy to see you all today. And I will introduce myself in Spanish too. Mi nombre es Kiara y me encanta estar con ustedes hoy día. Y quizás Rafa puede hablar sobre él un poquito.
Hi everyone, my name is Rafael and I'm a medical student here from Brazil. We'd love to hear where you guys are tuning in from and the level of training that you guys are, so we can get a sense of our audience. We really love this special VMR for us. And just to switch a little bit to Portuguese, meu nome é Rafael, sou aluno de medicina aqui da UEM do último ano. Se alguém quiser, a gente faz um pouco diferente nos sábados, porque geralmente é só o Rabi que discute. Então, mas ele sempre pede para alguém falar alguma coisa em relação ao caso no chat. Então, se alguém quiser falar alguma coisa em português, eu posso ajudar na tradução. Ou então, se alguém quiser falar... Sorry. Okay, so I'm just saying that I can help everyone that maybe have some trouble explaining their clinical reasoning in English. Maybe they can write in Portuguese and I can translate back to the team. And yeah, I hope everyone can learn and enjoy this afternoon with us. So maybe Sukriti can introduce and speak a little bit about herself.
Hi everyone. I'm not sure, my network isn't so great, so I don't know, I might get stuck with a funny face on, but I thought it would be fun today to introduce myself in Marwari, which is actually a regional language that we speak in Rajasthan. So my name is Sukriti, would be Maro Naam Sukriti hai. So a little bit about Rajasthan. I've never lived there, but I'm from there. My grandparents live there. So every Diwali, which is the Hindu festival of lights, I go to visit my grandparents, and my favorite thing to do there is to go to this place called Chaukidani, which is like a restaurant that gives you an experience of eating in a village setting, and you eat this this famous food of Rajasthan, which is called dal bati. So that's a little bit about where I'm from and a little bit of India. And now I'll pass it on to Anne-Marie.
Hey everyone, I'm Anne-Marie. I am just here to observe the magic. English is my first language, so I just love hearing all the different cultures and everything, and I'm thankful that I get to be a part of it.
Amazing. Kirtan, I see you hiding there. Tell us in your sweet, sweet language more about yourself.
Yes, so as Sukriti told that we have various languages, so probably I can speak in Gujarati. The Kushal knows Gujarati way better than me, but I can say that મારું નામ કીર્તન છે અને હું ગુજરાતમાંથી છું જે વેસ્ટર્ન પાર્ટ ઓફ ઇન્ડિયામાં છે, and we love sweets, તો અમને મીઠું મીઠું બહુ ભાવે, and we also like sweet things too. We like to tell sweet things to people, right? So that's how it works. And now I will pass to you to tell us about some Lebanese delicacy. I'm always waiting for Lebanese delicacy.
Ahla wa sahla, which means hello, hello. Ana ismi Rabia, my name is Rabi. And I am from a small town in northeastern Lebanon called Zahle. Lebanon is identified primarily by the capital city, Beirut, which before troubled times in the last few decades was known as the Paris of the Middle East, as it sits on the Mediterranean coast facing westward, but a hub of Eastern intellectual ideas and history. It really is this fascinating mix of East and West, much like Turkey is in many parts of the dimension of the Mediterranean called the Levant there. And I was born there. I lived there for 3 years before my parents moved to work in a Lebanese international school. And so I spent some time in the United Arab Emirates, but most of my childhood in Lahore, Pakistan, an ancient city many, many thousands of years old, known for its street food. That street food comes with two things: yum, 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 and salmonella. So I've experienced both, and only recommend one. It's a delight to see you all here, and I'm really, really excited. Honestly, just to put it out there, salmonella is totally worth the yum, yum, yum. Like, totally. It's not even a question. So I'm excited to hang out with you all today, as per usual. I'll tell you that the whole goal is to elevate as many different voices in as many different languages. So I encourage you to participate in the chat, and you can say your comments in English or any other language, and I will ask you to unmute yourself and say them out loud so we get them for everybody else who watches this, all of this offline. So without further ado, a dear friend and a CP Solvers team member has a case for us today. So Kiara, jump on in. We can't wait to nerd out with you.
Okay. Well, yeah, so it's not just, it is not well prepared, but maybe I can tell it as it happened. Is that okay?
Absolutely.
In the order that it happened.
Yeah, of course.
Okay, so the chief complaint is headache. Maybe you want me to continue with the HPI?
I think we can stop there, actually. And I'm curious what
Okay.
things as they hear that. When they hear that the chief complaint is headache, what thoughts cross your mind? And I'll mute for 30 seconds and allow the chat to share some thoughts.
Which mind?
Francisco, please unmute yourself and tell us more.
Well, hi, I'm
Hi.
Francisco. I'm from Peru as well as Kiera. I would like to know about the onset because there are different pathologies, maybe an subarachnoid hemorrhage and many other things that may be such an acute onset. It will differ from more an insidious or chronic onset.
Fantastic. That sounds absolutely correct. I think knowing the key is to differentiate between sinister and non-sinister causes of headache. And I think everything that you mentioned really helps us identify that. Francisco, I see that you have in your picture a dog with you. Tell me more about your dog.
Well, his name is Argos. He is like 8 years old. He's a Dalmatian. It's a little short for a Dalmatian, for a common Dalmatian, but that's it. That's my dog.
There's somebody here who wants to say hi to Argo. His name is Nar, and he's sleeping right here between my bag and my. Anyway, thank you. That was very, very helpful. Natalia, do you want to share more what you think about primary and secondary? Just unmute yourself, please.
Oh, I am kind of scared because
I
don't.
Look, he's not scary at all. He's very nice. Look at him.
No, about the dog. That's because I am not usually talking in English.
Yeah.
But I think that we should certainly have to answer to question about the age and question about the medicines that the person use, and see if there is another signs like fever, like diplopia, and we have to question about the time that beginning, if and how much pain this person is feeling, and things like that. But I don't know, it's kind of hard to just clinical reasoning in English. It's difficult.
God. I can only imagine how I can't even begin to imagine doing this in another language. So I especially appreciate your willingness to do so. Can you tell us more about yourself?
Oh, I am from Brazil, a little city in Brazil. It's called Água Boa. Is in the state Minas Gerais, and I am a medical student. But with the pandemic, there is like more than 1 year that I don't have practical classes.
Yeah.
So there is like I started to go to this meeting this week, and I am loving it. It really helped me, and I am so excited to learn with you guys.
Well, it's a pleasure to have you here. Thank you for joining us. Stavan, you have some really interesting thoughts. Do you want to unmute yourself and tell us more?
Okay. So my name is Stavan, and I'm from Gujarat, that is in India.
Yes.
Actually, yeah, I and Kirtan are very good friends of each other, and that is how I have started, the CPS solvers. He introduced me to this, and I'm really excited about participating in this for the first time.
Wonderful.
So, yeah.
He's a friend of Kirtan, is a friend of the family for sure. Thank you for joining us.
Oh, yes. So, yeah, my thoughts are that first we should ask that since how long is this patient having the headache? And apart from that, we have to localize it. That is it unilateral, bilateral? Then we have to ask about the age. And most important is the severity. Like, let's see that is it mild, moderate, severe based on the grading from out of 10. So if we see the common causes, it could be migraine. Yeah, like it's one of the most common causes, right? Pulsatile headache and very severe. And so yeah, migraine should be kept in mind. Then second, it could be even a tension headache. That is also becoming very common with the increase in issues like depression. Then it could be even a cluster headache, right? It could be recurring and it's of severe nature. Then we should also think about the trigeminal autonomic cephalgias, right? It's again, means cluster includes that even the Suna and even paroxysmal hemicrania. So, right, all these are the common causes which we should keep in mind. Yeah.
That is a great analysis of the causes of a headache, and also you went in a deep dive into the primary causes, and I completely agree with you. I think headache is no different than a chest ache or abdominal ache or arm ache or leg ache. There are some very benign reasons why somebody's chest would hurt, like costochondritis, or abdomen would hurt, like a muscle strain. And the tension in a headache is not finding tension headache. It's finding all the other scary things. So if you analyze it from a distance, you'll say some things that cause headache, I will never be able to diagnose with imaging. All I want to do is to pick up the causes that result in identifiable pathology within the brain. Right? If you're trying to say, I cannot see a tension headache, I cannot see a migraine, I can see an intraparenchymal hemorrhage, I can see a mass, I can see the effects of giant cell arteritis on the blood vessels, I can see and look at evidence of lumbar, of meningeal inflammation on an LP. And that's the goal. The goal is to say, how can I never miss the causes that are readily identifiable with absolute certainty by imaging or assessment for for meningeal inflammation? And that's the key question. I'll share with you that what you are looking for is to make sure that you do not find a secondary headache cause, which may live in the brain parenchyma, which may live in the ventricles, in the vessels, or the meninges. So you're like, I want to make sure there's nothing in the brain parenchyma, ventricles, vessels, meninges. But you have to recognize that those are not the only causes of secondary headache. There are things in the eye and in the face that can cause a secondary identifiable headache syndrome, like acute angle closure glaucoma or herpes zoster reactivation, or systemic effects that are readily identifiable diseases that can be treated, like obstructive sleep apnea, which can be oligosymptomatic and present as a headache predominant disease. There are extracranial infections that have the headache so prominent that the patient can ignore other symptoms. These are things like influenza, which can present with fever and headache, and mild upper respiratory tract symptoms, mononucleosis infections, dengue, and rickettsial organisms. And of course, some rare considerations. So what's the takeaway? Your job when you're thinking about a headache is to never miss anything in the parenchyma, ventricles, vessels, and meninges, but also the eye, the face, and some small categories of systemic diseases that are identifiable pathologies that have systemic features which can be small compared to the size of the headache. So I'm sure Chiara will give us information, but don't forget the vessels, the parenchyma, ventricles, vessels, meninges, face, eye, and systemic causes. A lot to keep track of. All right, Chiara, back to you.
Wow. Wow, amazing discussion. And okay, so I just will continue. This is a 71-year-old male who presents to the ED with 4 days of a new onset and diffuse headache, right palpebral ptosis and diplopia. This pain was referred as 10/10, and it exacerbated with eye, neck, and any kind of facial movements. A little more about his past medical history. He was diagnosed 10 years ago with Sjogren syndrome, also with type 2 diabetes 4 years ago, complicated with diabetic retinopathy and neuropathy 2 years ago. Also, he has chronic gastritis, venous insufficiency, and benign prostatic hypertrophy. About his medications, he takes ophthalmic drops like cyclosporine ophthalmic type A, pilocarpine, NSAIDs, steroids, metformin, glibenclamide, pregabalin, tolterodine, ranitidine, and calcium dobesilate. He is from Peru. He lives in Peru. He's a Navy veteran. He has no recent travels or exposures. He does not consume tobacco or other illicit drugs. Yeah, I think that I can stop here.
Sounds, whoa, it really got very, very intriguing. And I see a lot of thoughts pouring into the chat. I'm going to give the chat another 10 seconds just to keep typing in, and then we'll reflect as a group, okay? So maybe we'll start. So Alexander, do you want to unmute yourself and tell us more about the ptosis and diplopia?
Hey, everybody. So I was just thinking about how, I guess that was something that jumped out to me. I was thinking about how that could be related to dysfunction of the oculomotor nerve in some way. I guess the most scary thing that might jump to my mind would be like an aneurysm of the posterior communicating artery. But I guess I don't want to close in on that either. I guess this could just be like they could be unrelated. The ptosis could be due to like lack of sympathetic output as opposed to just due to the like third nerve dysfunction. So you could be thinking about dysfunction of the carotid artery in some way. Obviously, there's a lot more to this, but those are just some thoughts running through my head.
Absolutely love it. I have nothing to add. That's absolutely brilliant. Ilana, hello. Do you want to unmute yourself, introduce yourself to the VMR crowd and tell us about your thought?
Hello, I'm Ilana. I'm a medical graduate from Brazil. And I'm from Recife. It's a town in the northwest of Brazil. I graduated in the end of 2019, just before the pandemic. And well, for this patient, I would think maybe an herpetic ocular infection because he has some ocular complaints, the ptosis and the diplopia, and also with the diabetes and the Sjogren, it's predisponent factor. Well, it's a risk factor to developing such infections. I would see if there is any redness to the eyes, if it's just unilateral, something that worsens the pain or not. And well, that's it. I would go for a more accurate ocular exam.
I think that's spot on, my friend. I think there's a lot of tension here between, do you go to the eye as you were thinking about, or do you go to the brain as Alexander told us? And I think that the clues that you said to look at the eye to see if it's red is very helpful. And we'll reflect on that in much more detail in a moment. I think Natalia has some really good thoughts about the history of Sjogren's and how that changes the analysis. Natalia, do you want to tell us more?
No, it's just because when I see autoimmune disease, I usually tend to think about other autoimmune disease causing something, because I don't know, autoimmune disease can cause a lot of symptoms and signs, and maybe could be the case, but I don't know.
Spot on, my dear friend. I completely agree with you. And Tiago is going to throw in some interesting dimensions about the pituitary. Tiago, do you want to unmute yourself and tell us more?
Oh, nice to see you all again.
Hello.
So yeah, it's very rare, but your schema is brilliant, and it says pituitary, and when you have a severe headache, it is possible to have a pituitary necrosis causing a very severe headache, and it can present with third nerve palsy. So it's just something to remind, but it's unlikely.
I think it's a very important reminder, primarily because of the morbidity associated with it, so I thank you so much for saying that. And then Hans reminded us of another thing to think about in the eye with glaucoma. Hans, do you want to tell us more about that thought? Let's unmute yourself if you have a moment.
Yes, when I heard that it was painful with the eye, maybe it has some closed angle glaucoma, which just suddenly happened.
Yeah.
But of course, we need further investigation here, look at everything in the face, eye, and so on.
Wonderful. I completely agree with you. Are you still in Germany, or have you traveled back to Canada?
No, I'm still in Germany, but I intend to travel back to the States. I still have step 3 to take, and I'm kind of stuck because of the pandemic here in Germany. But I got all 2 vaccines now, and I think
wonderful. I'm delighted to hear that.
So it should be possible to finally travel again.
I certainly hope so. I certainly hope so. Valeria, tell us more about that. That's a really, really good thought about the pupil.
Yes, it's actually something that Aaron taught us in a couple of VMRs. That the fact that with the pupil we can really get a sense of where is the location of the ptosis, and if it's caused by cranial nerve third palsy or something affecting that nerve, you will usually see changes in the pupil versus something that is not affecting the nerve, in which we wouldn't see the pupil affected. And so I was thinking that could make us rule out another possibilities. I don't know if, for example, when you have orbital cellulitis, that could also be the case. You could have maybe some sort of way affecting the pupil, but I think to differentiate those two, maybe I will look for that.
Absolutely, 100%. I think that's a very, very important pearl. Thank you so much. So let's summarize where we're at. We have right-sided ptosis and diplopia in the context of a headache. And I think the assumption that we probably make is that if we understand the cause of the ptosis and the diplopia, that will likely explain the headache. So it's interesting to see how all of us have gravitated to start to answer the diplopia and ptosis. And if we find the answer to that, it's likely that we'll find the answer to the headache. Diplopia is an interesting problem. It means that your brain is seeing 2 pictures, right? And the question is, why is there 2 images being perceived by your brain? Is it because your eyes are misaligned and they're seeing the world from two different perspectives, and that's why you have two different images? Or is one eye reflecting light within itself abnormally enough such that each eye actually creates its own two images within the eye itself? How do you know that? You ask the patient to cover their eye. That produces only input from one eye. And if the patient still sees double after you cover one eye, that tells you that the two images are being created by that eye. That is monocular diplopia. Now, why would an eye create two images? Often because there is a refractive error in the lens or the cornea that reflects light abnormally, making two images land on your retina. That is rare. More commonly, what happens is you have two eyes that are creating two different images because they are misaligned. So binocular diplopia, which is discovered when the patient covers one eye and the diplopia vanishes, telling you that the other eye is producing a separate image, localizing the problem to binocular diplopia. Now, why would the eyes be misaligned? The eyes might be misaligned because the nerves moving them are diseased, or there is something in one eye that displaces the eye. Okay? So, let's assume the most common scenario. The most common scenario is that we have binocular diplopia. And binocular diplopia is challenging because, the localization of binocular diplopia is very diffuse. It can be all the way in the eye itself because of an orbital disease process, or it can be because of neuromuscular weakness, which has a long differential diagnosis. How do you know? That's when I think Ilana's comment is crucial. Ilana told us that we must look for eye redness. Now, why is that really important? When we're looking for something in the eye, we're looking for what's called orbital disease signs. So these are signs that are very sensitive or specific to something being in the orbit. Now, what are those? Let me show you. If you are trying to diagnose an orbital disease process, which is a disease process that lives surrounding the globe or the eye, either the eye muscles or something occupying the space around the eye. Very specific signs to tell you something is in the eye is to see the eye pop out, to see the eye hurt when it moves, and to see the eye not move at all. These are very specific, but very sensitive signs are conjunctival injection and chemosis, or swelling of the conjunctiva. Why? Because the orbital process blocks venous drainage, causing redness and swelling to accumulate in the eye. So if you are faced with binocular diplopia, which we are here, the question is there something in the eye or something in the neuromuscular apparatus? And a very sensitive sign for something in the eye is the presence of conjunctivitis and chemosis. It is very hard to have a space-occupying lesion in the orbit, like mucormycosis, without that space-occupying lesion causing venous compression, causing conjunctival swelling. There is a space in the neuraxis that does both neurologic weakness and causes an orbital compression, and that's the cavernous sinus. If you get a cavernous sinus thrombosis, you block the actions of the cranial nerves, of which there are several, and you cause venous hypertension in the orbit. So that's one place that does both. What should we prioritize? Based on what we know, the fact that there's pain with eye movement is concerning, that there is an orbital disease process. But the lack of reported conjunctivitis or redness of the eye makes that less likely. So we still are, I think, entertaining both, and the exam will help us be much more confident in what is going on. How can Sjogren's syndrome be related? Sjogren's causes dry eyes, which may cause the patient to be vulnerable to orbital infections because of the lack of protection of the tear film, but it is also associated with a 30-fold increased risk of lymphoma, which can be in the orbit. Diabetes, especially if uncontrolled, may make us worry about stroke, but also make us worry about invasive fungal infections. So there's so many hypotheses that could be mapped onto the neurological localization of diplopia or the orbital localization of diplopia. And I think the next step is to localize it. And then after we localize it, as Aaron teaches us always, localize first, study the time course, and then make a differential diagnosis based on the combination of localization and time course. And so hopefully the exam will help us do that. All right, Kiara, back to you.
Wow, always amazed. So vitals were okay. Temperature was 36.8, heart rate 80, respiratory rate 18, SpO2 98 on room air, but the blood pressure was 155 over 85. On physical examination, there were no meningeal signs. He had ptosis, right ptosis. It was obvious. He had binocular double vision, strength, reflexes, tone, all were conserved. Also, he was evaluated by that time by an ophthalmologist and a neurologist who supported the diagnosis of diabetic retinopathy with normal intraocular pressure and a cranial mononeuropathy, so cranial periphery was affected. I will continue with some exams and some images too. So his hemoglobin was 12.5 and white blood count, platelets, glucose was 157, and then platelets, BUN, creatinine, arterial gases, urinary sediment, electrolytes were normal. There was a CRP of 0.7, which was under normal values, and also a brain CT with contrast and without contrast didn't show any significant findings.
All right. Kiara, may I ask you one question? So it sounds like the impression of the team was this person had a right-sided, isolated, pupil-sparing cranial nerve 3 neuropathy. Is that correct?
Yes, that was the first impression.
Okay, all right. All right, folks, I'm gonna mute this for 30 seconds. Let's keep the thoughts coming in the chat about how you think about all this, and I can't wait to learn from all of you. I'll give this 30 seconds, okay? Oh, my friend Jose, tell us more, please.
Okay. When I read that facial movements exacerbate the pain, I thought about anything affecting the cranial nerve 5, because it's responsible for the sensibility of the face.
I couldn't agree more. The key question now, my friend, is we know cranial nerve 3 is involved, but are there any other cranial nerves involved? And if cranial nerve 5 is involved, we have to try to understand, is it V1, V2, or V3? And that helps us a lot. So I really, really like that you're thinking through that. Thank you. Francisco, what are you thinking?
Hi. Well, I really don't know, but the CRP value under normal values, it would like make a diagnosis of infectious disease or autoimmune disease like more distant, and maybe some local things. I was a bit concerned about that the pain would exacerbate with jaw movements. That would maybe rule in something like temporal arteritis or giant cell arteritis or some claudication, but that thing wouldn't go with the ptosis and the diplopia and those things. Indeed.
100%. I completely agree with you. I think it's hard not to worry the most about GCA, given the patient's age and the findings that we have. And I'd imagine a small fraction of patients with GCA, I think it's about 10%, have a negative inflammatory marker. So we really have to study the clinical syndrome. And it almost certainly reduces the possibility of it, but it certainly can't eliminate it. So Subhangi, can you tell us more about what you're thinking?
Hello, hi everyone. I'm Shubhangi. I'm from New Delhi, India again. So considering it's a global VMR, I'll just speak in Hindi because that's what we say around here. Namaste, मेरा नाम शुभांगी है. मैं नई दिल्ली भारत से हूँ. So this discussion is really interesting, and what made me think of diabetic neuropathy at the same time as Astavan did, he also said the same thing at the very time, that there's pupillary sparing. So what happens in the nerve is that the vascular supply, which handles the motor part, is outside. So that is usually affected when there is a compressive lesion. So, but when and due to medical reasons, the inner vascular supply is affected. So I think that if had there been a compressive lesion of the oculomotor nerve, we would have had a pupillary involvement. So that led me to think that it could be a diabetic mononeuropathy, considering he is diabetic. So that's what I thought, but I don't understand why that would be a unilateral, or that could start from the right nerve and then maybe it involves the left one later. So that's what I thought.
Brilliant.
And we also don't know if any other nerves are involved, and diabetes is prone to present with a mononeuritis, a multiplex.
Yes.
So we don't know if any other nerves are involved or not.
Beautiful.
Thank you.
I couldn't agree more with you. Superbly said. Nothing to add to that. Thank you so much. Jose, do you want to give us your problem representation in Portuguese? And I will ask somebody to do the same for Spanish if you wouldn't mind. And maybe Shubhangi, do you want to do it in Hindi if you're able to? If not, no worries at all. But Jose, take it away, please. I think we might have lost Jose. I don't see him here anymore. Anyone willing to do this in Spanish? All right, Maria, I'm going to need your help. What do you think is going on in Spanish?
Alright, so I'd say que tenemos un paciente masculino de 71 años con múltiples comorbilidades, incluyendo diabetes y síndrome de Sjogren, en múltiples tratamientos inmunosupresores, que se presenta con una cefalea subaguda, con ptosis, diplopía, y eso. Yeah.
Brilliant. Rafa, Portuguese.
I just want to point it out that Maria told me that I speak so many words per second, but I think she matches up with me or goes even further. Então, nós temos um paciente aqui de 71 anos, masculino, que se apresentou com uma dor de cabeça de forma abrupta, né, 4 dias. associada com ptose e diplopia. E a gente agora está tentando descobrir o que pode juntar os dois, tanto a ptose quanto a diplopia, com uma dor de cabeça também associada. É interessante porque a severidade é bem intensa e é exacerbada por movimentos, né? Então a gente tem o que nós chamamos de red flags, que seriam bandeiras vermelhas. Up to you, friend.
Beautiful. Oh, so well done. Shubhangi, are you able to do this in Hindi, or if you're not, that's okay too. I think we lost her. Oh, there she is.
Yes, I'll be able to do that in Hindi. Yes, I'll be able to do that in Hindi. Should I start with the problem and representation,
Yeah,
or should I
just the problem representation?
Okay, हमारे पास एक पेशेंट है जो 71-year-old एक आदमी है। वो 4 दिन से बता रहे हैं कि पूरे सर में दर्द हो रहा है अचानक से। वो उनकी आँख झुक रही है और उनको 2 दिख रहा है उनके दाएं साइड पे। उनको काफ़ी ज़्यादा दर्द हो रहा है। वो इतना बताते हैं कि 10 के ऊपर 10 उनको दर्द महसूस होता है और उनका दर्द बढ़ जाता है जब वो अपनी आँख हिलाते हैं या सर हिलाते हैं या अपना कुछ जबड़ा हिलाते हैं, तो उनका सर दर्द हो जाता है। So that is the problem and representation in Hindi.
Brilliant, my friend.
Do you like anything?
Thank you so much. Thank you all. I think if we reflect deeper on the, and I'll do it in Arabic. No, I can't. I wish I could. Medical Arabic is very hard for me. I actually wouldn't be able to tell you. I think what's really interesting about this case is the thoughts of everybody anchoring around cranial nerve 3. And I think that if we analyze, well, what causes cranial nerve 3 dysfunction, we'll recognize that diseases within the brain. Can you all see the ophthalmoplegia schema? Yeah. Okay. Sorry, I'm having a lot of issues with my Zoom today. You guys see ophthalmoplegia? Is that what you see? Okay. All right. So as we've learned a lot from Aaron, you can localize this problem to the brain. You can have brainstem causes and subarachnoid space disease cause cranial nerve 3 dysfunction. But the localization can also extend into the nerve, the NMJ, and the muscle. And so here, we took the ophthalmoplegia and we said, hey, the neurologist and the other folks on the team localize this to a nerve problem. And so what can happen as a nerve problem? We have thought about a PCOM aneurysm, but the imaging makes that less likely. We thought about a pituitary adenoma, but the imaging makes that less likely. We thought about cavernous sinus disease, and we took a picture of that, and that makes it less likely. There are some other localizations too that can happen as a compressive neuropathy. There are, of course, some very important non-compressive diseases to consider, and a lot of them have been mentioned: diabetic cranial nerve infarction, leukemic infiltration, thiamine deficiency, of course, and others. So what do we use as other clues? It's hard not to minimize the risk of non-compressive cranial nerve 3 neuropathy in light of the imaging findings that we have. We haven't shown that cranial nerve is compressed. And so it's easier to gravitate towards the non-compressive causes because the imaging doesn't show that. And what other clues prioritize the non-compressive causes? I'd say because of how no-miss the diagnosis of GCA is, we have to entertain that. But it's hard to ignore the acuity of this disease process being less consistent with a subacute to indolent vasculitis, along with the fact that the inflammatory markers, namely both the hemoglobin, the lack of anemia, the lack of thrombocytosis, and the lack of an elevation in CRP, all mitigate that risk of giant cell arteritis. What can cause, what also explains the headache potentially is this rare syndrome called Tolosa-Hunt. And before I reflect more on that, I have to ask Chiara a key question. Chiara, can you tell us what came first? Did the headache come first or the ophthalmoplegia?
Actually, I'm not so sure. I believe it's first the headache because it was like, yeah, it was acute. I hadn't had the chance to see this patient. It was my professor patient, and it was many years ago. I really cannot remember that.
That's
for
okay.
sure.
I think where we're at is we have to entertain non-compressive causes like thiamine deficiency, like malignant infiltration from leukemia and lymphoma, but an early consideration to the rare possibility of what's called Tolosa-Hunt syndrome, which is an idiopathic granulomatous disease of the superior orbital fissure, Why is that important? Because it is a granulomatous disease right next to the cavernous sinus that initially begins as a debilitating headache and is followed by a variety of cranial nerve abnormalities. If you don't think about it soon enough, the patient can have permanent ophthalmoplegia. So we'll have to think more about that. And I think the key question is, why is cranial nerve 3 involved? Is it because of subtle compression that we've missed on the imaging we've had? Is it diabetic infiltration, malignant infiltration, or an autoimmune disease like Tolosa Hunt? All right, Chiara, back to you, my friend.
I don't know how to divide this again. Okay, I think I will give you like a big aliquot, then a small one, and then a final diagnosis. So about his evolution, he was started with NSAIDs therapy, but after 24 hours the pain was not controlled, so he received IV tramadol, but he had hypotension, nausea, vomiting, probably due to tramadol, IV tramadol, so this was rotated to ketoprofen with pregabalin, and he received a new ophthalmologic evaluation and an ophthalmic angiography that did not show any significant findings again. He was hospitalized, and by day 17, he had a geriatric consultation that showed mild functional dependence, but his baseline was totally independent. He had intact cognition, he had a depressive disorder and malnutrition. So a new physical exam showed that he had bilateral pain in the temporomandibular joint, right eye twitching, and pulsatile headache in the temporal region. This pain was predominantly nocturnal with some paresthesias in the right hemiface and bilateral upper maxilla. Also, he had allodynia in the right temporal region. Pregabalin was increased, morphine was started, he had a rheumatology consultation, and new labs came. So IgG, IgM, anticardiolipin, antibodies, antiphospholipid, lupus, all the rheumatology panel was negative. ESR was asked once, but it was negative. And a temporal artery Doppler was performed, and it didn't show any significant findings.
Oof, a lot of interesting stuff here. I got to tell you, I'm bouncing between towards GCA, then back away from it, then towards it, and back away from it. I'll mute for 10 to 15 seconds and see where you all are at. Kirtan, tell us more.
Yes, so Ravi, exactly like you, I'm also bouncing back and forth between GC and everything else. But just one of the things I wanted to mention, that in your schema, when you showed us the ischemia thing, so back in my medical school, I learned that GCA can even affect the vessels, which hits the cranial nerve itself. So it can even cause optic neuropathy. It can cause third, fourth, fifth, all the cranial nerve pulses. It can even cause laryngeal arteritis. So all the cool things. And then very rare one thing, since now nothing else is left, I have to mention that few months back, one interesting case came in NEGM, wherein the patient had temporomandibular joint involvement as well as the pulsatile headache. And the final diagnosis was systemic amyloidosis, because amyloidosis is one of those diseases which can affect the temporomandibular joint, and not many diseases can hit the TMJ. And since it was so prominent that Chiara mentioned it in the second aliquot, now I'm biased toward it. But now, Rabe, you can help us how we can move forward.
I think that's exactly the right way to think, is what can cause temporal arteritis, but what is also a mimicker of temporal arteritis. And I think that other vasculitides can involve the temporal mandibular joint, but another vasculotropic disease process like amyloidosis is very important. And thank you so much for for mentioning it. That's absolutely brilliant. Maybe for the sake of time, since we only have a few minutes left, I'll pass the mic to Kiara to tell us more right before the final diagnosis, and then we'll all reflect as a group.
Yes. Okay, so this patient was reported, so the patient reported pain relief, but intestinal subocclusion, morphine was rotated. He had many changes on pain management, but prednisone was started and the pain relief was achieved 3 days after. So the patient was discharged. He was followed up for 4 months. I know you all want a temporal artery biopsy, but the patient denied for that, so this wasn't an option right now. So the patient was discharged, follow up for 4 months, and he was re-hospitalized twice for respiratory infections. However, during the last hospitalization, the patient suffered sepsis and he died because of cardiovascular complications. After that, an autopsy was performed, and this autopsy will reveal the final diagnosis. I don't know if you would like me to say it right now.
Yeah, that's really unfortunate. I'm sorry we learned it that way. I'll say that everyone should take maybe 5 seconds to practice what they think is going on, and then why don't you tell us, just for the sake of time, Kiara, what the final diagnosis was? All right, go for it, my friend.
Okay, so the heart autopsy showed myocardial infarction, and the temporal artery showed mononuclear infiltration in the inner layer and of the temporal artery and multinucleated giant cells infiltration. So that confirmed the diagnosis of giant cell arteritis.
What a heavy and hard way to learn that diagnosis. I'm sorry that your patient died in the context of all this. Can you tell us more about your experience being part of this case and what you learned and where you stand now, Kiara?
So I haven't had a chance to meet the patient. I knew about him the same year it happened because it was my patient professor, but there's some learning point I can have about this. One is that an appropriate management is needed, and this patient was almost abandoned. He had malnutrition, and I believe that a prompt diagnosis wouldn't lead to this fatal disease or final. Also, some things that lead like this delayed diagnosis is that they like put giant cell arteritis like a little far away because this is not frequent in Latin American populations. At least I don't know reports in Peru about giant cell arteritis, and obviously there is a criteria for the American College of Rheumatology that recommends the biopsy, but this patient denied for that. And also the thing that he had ESR and CRP negative was like pushed the diagnosis a little far away, but it also was mentioned that at least in 17% of the cases, these values are not elevated. And another important thing is that there are very few reports that associate giant cell arteritis with Sjogren, but those few reports that associate those diseases commonly associate with polymyalgia rheumatica and also with something else, and follicular lymphoma. So those are the reports I have seen, but that's all I know.
Oh, this is super, super helpful. Thank you so much for teaching us so much today. You can see the comments in the chat that the amount of education that you brought here today for us. And I think that's, despite the patient being abandoned in many ways, you're certainly not abandoned by you. And here we are learning so much about a very important diagnosis. Thank you so much. All right, Rafa, take us home, please.
So thank you, Kiara, and thank you everyone who joined us today. So we had a 71-year-old male with headaches. And when it comes to headaches, we tend to think about primary and secondary causes. primary including cluster, tension, migraine, trigeminal neuralgia. And when it comes to secondary headache, we have to go after the cause. For example, if the patient is having fevers, we could think about meningitis, or if the patient has vision abnormalities, we could think about GCA or acute angle closure glaucoma. And then we have to remind about the red flags associated with headache, the SNOOP, so systemic symptoms, neurologic deficits, the onset, for example, if it's acute, we could think about SAH. And if the patient is older or position aggravational. And then we saw that this patient had ptosis. Ptosis is actually droopy eyelids and could be a problem in the cranial nerve 3 palsy, but also a problem in the oculosympathetic pathway or a neuromuscular junction disorder. And we can see that, for example, in the side of Horner syndrome or diabetes and many other etiologies. When it comes to diplopia, just like a rabbit taught us, it's double vision. It can be bi or monocular, and the eyes are misaligned. So if we have a nerve palsy, it's probably binocular and resolves when one eye is closed. But if you close an eye and it doesn't resolve, we have to think about monocular causes. And it's usually a lens problem, like astigmatism. And then we saw that this patient had Sjogren. It's an autoimmune disease with destruction of the exocrine glands, and there are many extragranular manifestations that you have to remember. For example, arthralgia, arthritis, sclerosis. This patient, they tend to have more caries, for example. And there's this spiral that this patient actually have increased risk for B-cell lymphoma. And then we saw that this patient was ultimately diagnosed with giant cell arteritis, which explains the headache, but we can also see jaw claudication, and it's usually in elderly females, and may lead to irreversible blindness. So we usually treat the patients with prednisone before the biopsy, and it's also associated with polymyalgia rheumatica. And just now, Kara's taught us that it could also be associated with Sjogren. So thank you, everyone. Hope everyone had a good day, and I hope to see everyone tomorrow.